Very good evening, everyone, and thank you so much for joining. No thrombosis program. No thrombosis program. Specifically, we are doing it from since last 2 years, and specifically, it is very successful. No thrombosis platform. It is all because of you, and all our faculties and the contributions and a lot of insights, specifically in anti-thrombotic specific kind of patients. And we also have received, SIMS Excellence Award, that is most engaging scientific platform from SIMS Medica. So thank you so much to all the delegates and the faculty. Because of all of you, we have received this, award specifically for no thrombosis. And today's, no thrombosis specifically program is very special and very dedicated to all the, the young cardiologists. So there are today's our course director is Dr. Anil Saxena sir. Dr. Anil Saxena sir is currently working as Executive Director of Cardiac Pacing and Electrophysiology at the Scott Heart Institute and Research Center. Dr. Saxena has worked for last 32 years in Scott Heart Institute and Research Center. Dr. Saxena was one of the first. Dr. Saxena sir was one of the first in the country to implant an ICD in 1995. He is also a past president of Indian Heart Rhythm Society. Saxena sir is also an associated editor of PACE Journal, and also he was a chief editor of APHRS newsletter. He is also an investigator and co-investigator in research product like Optimize, Rocket AF, Validate, Panorama, Attain, Success Study. So Shockless study and Emcure 6621. So there are many studies on research product where he has contributed as an investigator and co-investigator. So, and not only that, he has also published more than 30 articles in international and national journals, delivered talk in many international conferences and symposiums. So from behalf of Emcure, I welcome to Dr. Anil Saxena sir for our no thrombosis platform. For today's our next, the moderator is Dr. Vinayak Agarwal sir. Dr. Vinayak Agarwal sir, he has completed MD in medicine and DM in cardiology. He's also done a fellowship in FACC, FASC, and FAHA. Dr. Vinayak Agarwal sir is a head of Department of Non-Invasive and Clinical Cardiology at Fortis Memorial Research Institute, Delhi. With 20 plus years of experience, his responsibilities including being in charge of Heart Valve Clinic and the Hepatic Transplant Cardiology Division at the Institute. Dr. Agarwal sir has spent a considerable amount of time on research, having conducted numerous clinical trials. So once again, from behalf of Emcure, we welcome Dr. Vinayak Agarwal sir on our today's no thrombosis program. Our next moderator is Dr. Samir Kuba sir. Dr. Samir Kuba sir, he has completed MD, DNB, MNAMS, DM in cardiology. He has also completed many fellowship like FSCAI, FACC, FESC. He is also a director and unit head, clinical and interventional cardiology at Max Healthcare Delhi. Sir has participated in many clinical research program as investigator and co-investigator, and published many kind of books, as well as he has given many chapter publication and newsletter publication specifically in the Times of India. There are many times it has been published. Sir has contributed very well, significantly contributions to patients' knowledge, enhancing the patient's knowledge and the disease knowledge to all the people. So once again, from behalf of Emcure, I welcome to Dr. Samir Kuba sir for our program. So our first speaker is Dr. Kavita Tyagi. Dr. Kavita Tyagi has completed MS DNB and DNB in medicine, DNB in cardiology. MNAMS, he has also done fellowship in FIMSA, AFESC, AFAPSC, like FN in interventional cardiologist, as well as he's presently working as a consultant cardiologist in Dharamvira Heart Center, Sri Gangaram Hospital, Delhi. So once again, from behalf of Emcure, I welcome to Dr. Kavita Tyagi for today's program. Our next speaker is Dr. Yannar Shastri sir. Dr. Yannar Shastri sir is a well-known interventional cardiologist, as well as he is presently working as a consultant preventive and non-invasive cardiologist in Mulchand Hospital, Delhi. So welcome sir for today's program. And our next speaker is Dr. Ayush Shukla. Dr. Ayush Shukla is an international cardiologist. He is presently working as an assistant professor at Department of Cardiology, King George Medical University, Lucknow. Dr. Ayush Shukla has published more than 10 articles and as well as, specifically participated in national and international conferences. So once again, from behalf of Emcure, I welcome to Dr. Ayush Shukla sir for our today's program. Our today's agenda is specifically the first case will be presented by Dr. Kavita Tyagi on high ischemic risk patients with CAT. Second, case presentation by Dr. N.R. Shastri sir. He is going to present on case study on patients with CHAT-BET score more than 3 and hemorrhagic stroke. And Dr. Ayush Shukla sir is going to present specifically a case on NOVAC in patients with NEAF, why and when. So with this, I hand over today's sessions to Dr. Anil Saxena sir, Dr. Vinayak Agarwal sir, and Dr. Samir Kumar sir for their further intervention. So over to you, Anil Saxena sir, Vinayak sir, and Samir Kumar sir.
Thank you, Ravi. It's indeed a pleasure to be here with all of you this evening, and I'm sorry for being a few minutes late, but it's indeed a pleasure, and I welcome all the co-faculty and audience on behalf of the organizers. So I think we have a very eminent faculty and panelists today and moderators today. I've worked with many of them, and it was indeed a pleasure to work with Dr. Vinayak, Dr. Kavita Tyagi, and it will be very nice to interact with them this evening. We have very nice topics for presentation today, and I will request my moderators, Dr. Samir and Dr. Vinayak, to start the proceedings. Is Dr. Samir there? Dr. Vinayak is there. Dr. Vinayak, you can start. Okay, yeah, Dr. Samir is also there.
Yeah. So I think we can start with the first case, and then after the first case is completed, we will all deliberate on that.
Yes.
Yeah.
So good evening, sir. So nice to see you. And good evening, everyone. So I'll start my... So we have a case of coronary artery disease along with peripheral artery disease. So 61-year-old male, complaint of chest discomfort on exertion class 2nd.
Ma'am, sorry to interrupt you. Can you please make it full screen, ma'am?
Okay, yeah.
Presentation.
Yes, ma'am.
Yeah. So patient had simultaneously history of claudication since last 1 year. Patient is diabetic and hypertensive. Patient has CAD. He has undergone PTCA plus a stent to LED 12 years back and CABG 10 years back. PTCA plus stent to RCA 3 years back. And he also has diffuse erytheromatous disease of bilateral lower limb. ECG shows sinus rhythm with LVH changes as patient is hypertensive. Echo shows mild LV dysfunction with RWMAs of inferior valve. Doppler studies of both lower limb shows diffuse disease of anterior tibial and posterior tibial arteries. And coronary angiography shows patent Lima to LED graft and SVG to PDA, LED and RCA total occlusion, and RCA mild CAD, LCX mild CAD. So diagnosis of this patient is coronary artery disease with triple vessel disease with grafts, along with peripheral artery disease and diabetes and hypertension. So patient is on tablet aspirin 75 mg once daily, rivaroxaban 2.5 mg twice daily, rosuvastatin 20 mg once daily, metoprolol 50 mg once daily, ramipril 2.5 mg once daily, ranolazine 500 mg twice daily as he has ischemic burden left, and sitagliptin with metformin once daily. So if we see this REACH registry, which showed 4 years outcome of a large number of patients, that is 64,000, who are more than 45 years. So patients of risk of CV death, MI, or stroke at 4 years, patient who had only risk factors, they were having 9.1%, stable atherosclerotic disease 12.2%, and prior ischemic event more than 1 year, and prior ischemic event last year more than even 7.2%, 17.2%. So it is increasing as the profile of the patient is changing from only risk factor to CAD, to a prior ischemic event, and to a prior ACS maybe. So current medical vascular protection comprises 4 pillars, as we all know. We are practicing them. Vascular protection therapeutic pillars are, it starts with lifestyle everywhere, healthy diet, physical activity, smoking cessation, weight control, psychological, psychosocial support, etc. And we have lipid-lowering agents, statins, we add as it might, as it required. And for uncontrolled LDL, we do add PCSK9 inhibitors. Blood pressure control, we have ACE inhibitors, ARBs, beta blockers, CCBs, and diuretics depending on the requirement. Blood glucose control, we have insulin, metformin, sulfonylureas, and so many drugs we are giving nowadays. Antithrombotic protection, we have aspirin and dual antiplatelet therapy. So these are the 4 pillars and given to almost all the patients depending on their baseline level of blood pressure, blood glucose level, their LV function, their lipid levels, and their basic cholesterol profile. And all of us, post-angioplasty patient, or rather CAD patients, we give aspirin and another dual antiplatelet therapy agent. So is there any scope for improvement with current antithrombotic regime? So they are basically, what we are giving currently is antiplatelet regime. So now this is a concept of antithrombotic regime. So can we improve on this? Now, if we see these novel oral anticoagulants, we all are familiar with. So this is initiation, then propagation, comes to factor 10, for which we have these inhibitors, ivaroxaban, apixaban, edoxaban, etc. And factor 2A inhibitors, we have dabigatran. So if we see this antithrombotic treatment strategy in patients with CAD, we go one by one. So if we have patient stable CAD on ecosprin monotherapy, if this patient has a history of multivessel CAD or MI more than 1 year, then we see whether this patient has some additional risk factors like diabetes, whether he is having PAD, whether he is having some kidney issues, whether he's heart failure, or prior non-lacunar ischemic stroke. If these risk factors this patient has, which is apparently a stable CAD on ecosprin monotherapy, then indication for oral anticoagulation, we see whether it is anticoagulation or high-risk features like life-threatening bleeding, anemia, ST of spontaneous basal bleed, bleeding diathesis, etc., severe liver disease or intracranial vascular. So we will see in short that if patient is having all the indications, if patient doesn't have, like if patient is not requiring anticoagulation for atrial fibrillation, patient is not high risk feature for high bleeding risk, patient is not a liver disease, patient is not having any intracranial vascular abnormality, then we can go for this like aspirin plus rivaroxaban 2.5 mg BD. This is this patient which is having a stable CAD on ecosprin monotherapy so far, but having these risk factors. So this is what our understanding. Now about starting rivaroxaban along with the ecosprin. Now patients who admitted with MI and treated with DAPT. Now if these patients have undergone coronary angiography following bypass, so up to 12 months we give DAPT, we all know that. Then after that we again follow this patient through these guidelines, like if patient is having risk factors, if patient's bleeding risk overall is low, then we again after 12 months of DAPT on this patient who hasn't undergone a CABG, we can follow this path of ecosprin plus rivaroxaban 2.5 mg. Now, people who have undergone PCI in this setting of MI and treated with DAPT, so in them also we'll see multivessel, extensive diabetic PAD, etc., or intolerance to ticagrelor, then history of ischemia. Then finally we'll see the bleeding risk. Then prolonged DAPT with aspirin plus ticagrelor. We can titrate maybe 90 to 60 mg BD from 1 year post-MI patients. So likewise, depending on the risk factors, depending on the setting the patient came to us, like stable or admission with heart attack, depending on patient is having bleeding risk, we can give our patient aspirin and rivaroxaban combination. So there are new guidelines recommended. A second antithrombotic for selected patients with chronic coronary syndrome, because so far we were calling like stable coronary artery disease, but now people are understanding that coronary artery disease is never stable. It's always a chronicity of coronary syndrome which is going on. There's always a plaque which is almost any time ready to, rupture and make a thrombus and can create an ACS. So 2019 guidelines for the management of CCS, adding a second antithrombotic drug to aspirin for long-term secondary prevention should be considered in patients with a high risk of ischemic events and without high bleeding risk. So 2A class. Adding a second antithrombotic drug to aspirin for long-term secondary prevention may be considered in patients with at least a moderately increased risk of ischemic event and without high bleeding risk. So this is 2B indication. Now, how we define high ischemic risk is like diffuse multivessel CAD with at least one of the following: diabetes, recurrent MI or PAD, or CKD with EGFR of 15 to 59. Moderate ischemic risk is defined as at least one of the following: multivessel or diffuse CAD, diabetes mellitus requiring medication, recurrent MI, PAD, heart failure, and CKD of GFR 15 to 59 ml per minute. So, dual pathway inhibition targets both platelet activation and persistent thrombin generation in chronic CAD, what we call as chronic coronary syndrome. So, if we see this cumulative risk of secondary event in acute phase, so preventive strategy is DAPT, platelet activation strongest in acute phase. After that, this initial event leads to arterial thrombosis, but after that, there's a prolonged thrombin generation event which is going on. So in this chronic phase, preventive strategy, we normally, we have been giving SAPP, but now we are focusing on giving this dual pathway inhibition, wherein we are inhibiting platelets also and thrombin generation. So dual pathway inhibition therapy. So antithrombotics for secondary prevention, trial-based comparison if we see, then we have the Capri's for clopidogrel, Karishma for clopidogrel, aspirin, Pegasus for ticagrelor and aspirin, Pegasus ticagrelor 60 plus aspirin, and so on and so forth. So we have seen that there's multiple advantages. Majorly, like in this combination, there was a major reduction of -27%. In this combination, if we see this ticagrelor 90 plus aspirin, the TIMI major bleeding was 160%. And if we give a ticagrelor 160 plus aspirin, then TIMI major bleeding was 132% likewise. So COMPASS is the only antithrombotic regime which is going for reduction in all-cause mortality. So patient profile based upon COMPASS inclusion criteria. Patient must meet criteria for CAD, PAD or both. CAD patient is defined as previous MI within last 20 years, multivessel CAD with symptoms or history of stable or unstable angina, or multivessel PCI or multivessel CAD. Patient with CAD must meet at least one of the following: age more than 65, or if age is less than 65, plus atherosclerosis in more than 2 vascular beds, or more than 2 additional risk factors like current smoking, diabetes, EGFR of less than 60, heart failure, or any non-lacunar ischemic stroke within more than 1 month of this. PAD patient definition: either patient has undergone revascularization or limb or foot amputation or history of intermittent claudication, wherein we define it objectively like ankle brachial, BP ratio less than 0.9, significant PAD stenting documented by angiography, previous carotid revascularization, CAD plus low ABI. So COMPASS trial was cardiovascular outcome for people using anticoagulation strategies. 27,000 patients were randomized. So they were randomized to rivaroxaban 2.5 BD with the ecosprin 100 mg, rivaroxaban 5 mg BD, and ecosprin 100 mg daily. It was the first NOAC and antiplatelet combination therapy trial to show significant reduction with a stable atherosclerotic disease. So primary outcome: MACE, CV death, stroke or MI, PC, ecosprin, rivaroxaban, and this was the combination. So clinical implications of COMPASS: switch from dual antiplatelet therapy to dual pathway therapy, that is rivaroxaban to plus ecosprin. Therapeutic use and clinical benefits of dual pathway therapy in both CAD and PAD patients. And so 2019 NICE guidelines, rivaroxaban plus ecosprin is recommended as an option for prevention of atherothrombotic events in adults with CAD or asymptomatic PAD with high risk of ischemic events. Thank you.
Thank you, Kavita. That was an excellent presentation. So basically, this dual pathway inhibition has come up in recent years as a very important concept, particularly in high-risk coronary patients. It may not be applicable to all patients with CAD, but certainly, as you pointed out, patients with PAD or with chronic renal disease, heart failure, diabetics, these are the patients who have high risk of coronary events. And not only that, but the COMPASS trial basically reduced the outcomes in as a composite endpoint, even though the reduction in MI was not significant, but overall there was a reduction, and it was largely driven by stroke. So what is I would like to now seek the opinion of my moderators, Dr. Vinayak. What is your practice? In which particular subset of patients do you consider giving dual pathway inhibition?
Thank you, sir, for that brief summary which you did, and absolutely correct. I feel if I am given a choice, I would always prefer a DPI, dual pathway inhibition, over dual antiplatelet pathway. Number one, if we look at Indian subset, we have a lot of almost 60% of our patients are diabetic. There will be some peripheral artery disease which we don't really scan for. And the maximum benefit of COMPASS was seen in those who had peripheral vascular disease, which was symptomatic in most cases, or was picked up for some reason, whether they underwent, a doctor study, or they had ABI testing, etc. So I feel that a dual pathway inhibition in patients where you suspect significant multi-vessel or multivascular bed involvement, the dual pathway inhibition is far more superior than a dual antiplatelet pathway. And the bleeding risk is actually same for both. And it also gives you, in addition to an antiplatelet action, an anticoagulant action. And we know that in a lot of these patients, thrombosis is common. So a dual pathway inhibition will make a lot of sense in this subset. Now, this study was mainly for chronic coronary syndrome patients, and we don't have so much of data in the acute coronary syndrome subset as yet, though there are studies which are going on. So I feel that anybody who's above the age of 65 having multivascular bed involvement, like carotids, peripheral vascular disease, CAD, who are at high risk of future cardiovascular events, should be on dual pathway inhibition. That is, and I follow that quite rigorously actually in my clinical practice.
Great. Dr. Samir, you are aware that there is a lot of hesitation among you. Must be talking to your colleagues in various conferences and all. And I still find that the offtake of rivaroxaban for this indication is still very, very small. In clinical practice, what we find is that not many cardiologists are prescribing a dual pathway inhibition. So, what is in your view the hesitation? Do you think it's less convincing evidence? We need more data, or we are not sufficiently educated about the correct indications? What are your views about it?
Thank you, sir. I think that's a very practical and wonderful question. And whatever we may discuss in the conferences, but when it comes to a practical usage of aspirin along with rivaroxaban 2.5 BD, I think the prescriptions which we see are minuscule. Probably the reason is we are so comfortable with dual antiplatelet therapy, especially aspirin and clopidogrel in the long run, because the data we have and the experience, our personal experience. In fact, if you ask me, even ticagrelor, after 6 months or 8 months, usually I have to stop in majority of my patients because they have some sort of nuisance bleeding. They will come to you that they have some ecchymosis over the skin, or they have some minor nasal bleed, and it may or may not be important for you, but it is very important for the patient that the bleeding is there. And I have seen when you switch over to clopidogrel, those things disappear. So more potent a drug in its anti-ischemic efficacy, more is the chance of bleeding. And it may be a nuisance bleeding. It's not going to cause much of an issue, but still it is there. And it's very important for the patient. Having said that, with the NOACs, somehow or the other, there is a hitch that probably the risk of bleeding may be higher when you compare it with aspirin and clopidogrel, although the data doesn't suggest it. And in fact, even in the COMPASS, it was a net clinical benefit, but still, sir, the risk of bleeding definitely was increased. So to me, I would agree to Vinayak on certain aspects, but again, there are certain caveats to that. To me, it's very important to analyze the patient as a whole, to assess his bleeding risk, assess his ischemic risk. And because you are committing this patient for a long-term therapy, it's not a short-term therapy. So you really need to understand which is the patient who is actually going to benefit. And at times, maybe using high dose of statin therapy and making the LDL level below 55, in majority of these patients, along with a single antiplatelet therapy also might be a very good strategy. Now that we are seeing that the primary prevention trial for aspirin and other things are actually negative. So it's more of a plaque stabilization without increasing the risk of bleeding. So I still do not have a very clear-cut answer to it, sir. But yes, high-risk patients as seen in the COMPASS. So the COMPASS type of patient, I really have to put my patient into that COMPASS category where benefit was shown. And again, looking at his bleeding risk, where the bleeding risk, I assume, is going to be lower, although you may at times be fraught with surprises. I recently had a patient, atrial fibrillation, LV dysfunction, class 1 indication for the NOAC. He was an apixaban, did very well. LV function improved. Maybe it was a tachycardia cardiomyopathy, but developed a massive intracranial bleed. And was supposed to, and when it was seen by a neurosurgeon, it was a glioblastoma multiforme, which actually bled. So, I mean, although a diagnosis came, so there are so many things to be discussed on it, and I don't think there's a clear-cut answer. But yes, this new pathway has opened up, and I believe we must use it with wisdom in the light of the clinical trials and our personal experience, which patient to use a DAPT, which patient to use a SAPT, and which patient to use a DPI. Thank you, sir.
Very nice. Very insightful comments. Kavita, you must have reviewed the literature around this. You have spoken so well. So did you come across any real-world data about usage of dual pathway inhibition where any results have been displayed or shown?
Sir, actually at our center itself, Gangaram itself, there's some trial going on, which we are actually giving the Rivaroxaban 2.5 BD with a constant, with this subset for our general OPD patients. Who receive Rivaroxaban for free. So they don't have any cost issues. But in them, I have certainly seen, sir, myself, almost 5 to 10% increase in bleeding because those patients were on stable antiplatelet therapy already. And now when I start them on this combination therapy, they certainly come with some bleeding problems, which as Dr. Kova said, maybe simply nuisance bleeding. Few patients we have found, sir, they were detected like some urological malignancy or some malignancy they were detected because some bleeding came from somewhere and we investigated and we found there was some underlying malignancy. So that was some blessings in disguise. Plus, with these subset of patients, sir, many of them, they are leaving from this trial. They say that they complain of some vague symptoms, some vague side effects. So we have to still report what are these vague symptoms. We have to still make a data of that. But many of our 10 to 20% of these patients have actually dropped out from this trial, which is going on with us, and we are working on that.
Okay, thank you. Thank you so much. I think that was a very nice presentation. So we can move on to the next case, and that is to be presented by Dr. N.R. Shastri. And he will present a case study of a patient with a high CHA2DS2, moderately high, that is more than 3, and hemorrhagic stroke. So this is a particular difficult situation that we often encounter. That patient has had a hemorrhagic stroke, means he's prone for intracranial bleeding, and the patient's CHA2DS2 is also high. And I assume we are talking about a patient with atrial fibrillation. So although it's not mentioned. So Dr. Shastri, your case, please. Is Dr. Shastri there?
Yes, sir. I'm just presenting. I'm sorry.
Shastri, yes.
Hello, sir. Yes, sir. So, 1 second, sir. I'm sorry. Yes, sir. So basically, this is just a very straightforward, simple case of a patient with a CHA2DS2 score of more than 3 and a presentation of a hemorrhagic stroke. So just before that, just a few basic briefings which I have. Now, I just written these down. So the presence of AF is roughly associated with a 5-fold increase in stroke. And the combination of ischemic stroke and atrial flutter together will increase the mortality risk. Now, the funny thing in this was this patient has been seen many times and he was having paroxysmal AF, which was never clinically evident in patients on admission. And this AF was present for many years. So coming to the, so it's important that we recognize that stroke presentation is vital, and there is a clear data on the use of NOAC to prevent stroke prevention. So this is a 71-year-old gentleman. He's very active. Apparently, he walks for about almost 1 hour daily in Lodi Garden. He presented to our emergency with a history of left-sided weak and unsteadiness of gait since morning. Practically almost, I think, since 7 a.m. in the morning, he came to us around at 11 in the night. So the past history was this guy is an educated person. He was retired as an IAS officer, and he's been on regular treatment for diabetes and hypertension for the past 10 years. He was metformin and metoprolol. And apparently, a few years ago, almost you can say 1 year back, his physician had actually got an ECG done, which showed that he was having erratic heart rate. At that time, he did not, because the heart was under rate control, he did not give anything. He just mentioned it as erratic heart rate, and he asked them to start taking Ecosprin. So apparently, when he took Ecosprin, for some reason, he stopped Ecosprin and switched him over to clopidogrel. So his medications were basically metoprolol, what you call twice daily, metoprolol sustained twice daily, atorvastatin, clopidogrel. Basically, a combination of atorvastatin, he was on something known as clopitorva, a combination of atorvastatin and clopidogrel, 75 milligram and 10 milligram once daily, and metformin once daily. So on examination, the patient in the emergency was disoriented. He had a heart rate of 82 beats per minute. The heart rate was irregular. His BP was 150 by 80. And he was having left-sided flaccid hemiparesis and an extensor left plantar reflex. The ECG at that time showed in AF with FPR, the heart rate was around 82 beats per minute, so it was a controlled rate. And no signs of any kind of ST elevation or depression. So blood sugar was okay. And the trop T was positive, but the trop I was negative, and afterwards his thyroid function test also came negative. At the time of presentation, immediately a CT was done, which showed a large acute non-hemorrhagic infarct in the right side, the IC artery. A follow-up MRI done showed a complete thrombosis of the right vertebral artery with the proper thrombus. So on calculation, his HADBLAS score came to around 5, and his HADBLAS score was 2. So since the patient had come more than 12 hours, and therefore we could not do any thrombolytic therapy for him. So we started on antiplatelets. He was given Ecosprin, statin, beta blockers, ARB, and oral antihypocoagulants. And he was kept in the ICU under observation. So his lab reports were roughly normal. So basically, the diagnosis we made was he was diabetic, hypertensive, and there was an acute non-hemorrhagic infarct. So he was kept under observation. There was his heart rate remained below 100. And he remained stable. And the CT done after 5 days again showed that there was no spread. So apart from his usual clopidogrel, he was also started on the rivaroxaban, 20 milligrams daily, which was a bit high initially, but then we brought it down to 15 milligram daily based upon his creatine clearance level. So he's apparently fine right now. Yeah, and yeah, that's about it. The rest is wrong. Yeah. So the key message is that basically atrial fibrillation needs meticulous workup and treatment based on guidelines. NOACs are right now a integral part of stroke prevention. And what is important is dose titration in renal impairment is very important. It is based on EGFR. Thank you, sir. Sir.
Thank you so much. Such a nice case. So, Vinayak, would you take the discussion forward, please? Actually, you're in your car. You're on mute.
So, I think I was actually in transition, so I lost a bit of the presentation in between. I didn't hear the full presentation.
Right, Samir, would you comment on this? It's a wonderful case.
Yes, sir. I think it's a wonderful case, a very practical case. This is something which we see day in and day out, and there are so many challenges. So the first learning for me from this case is what was actually the indication of aspirin in this patient to begin with. And this again reiterates the fact that aspirin being used right, left, and center, and I'm again contradicting my statement from the previous case that, or not contradicting, but for the matter of discussion, I have realized in my limited years of practice, and I think Dr. Saxena, you are so senior, you would have realized over a period of time that as you go in practice, the most important thing which I have realized is you really need to decide does your patient actually need that particular drug? Because any drug will have its own effects and side effects. So aspirin is something which probably was not indicated in this patient from the beginning. And maybe what he required was high-dose statin therapy with a good LDL cholesterol. And now we have data to prove that aspirin should not be used right, left, and center. And for paroxysmal AF, it's a class 3 indication. I mean, although the AF was
Class 3
diagnosed...
harm. It's class 3 harm.
So it causes harm, class 3. So that is my biggest learning from the case, and rest of the case management is absolutely straightforward once you've diagnosed an AF, once you've diagnosed a stroke. And I think, as Dr. Shastri very nicely mentioned, that the AF-related strokes are not only more common, but also more denser than the non-AF related strokes. And herein comes class 1 indication for the NOACs, whichever NOAC you want to use. And maybe rivaroxaban is ideal in this scenario. He's an elderly man and it's once-day therapy, so compliance is going to be better. The timing of starting this therapy and how to go about it, obviously, we usually do in the conjunction with our neurology colleagues, because that guidelines also keep on changing. But I think the bottom line to me, sir, the most important point learning for me from this case is you should not use aspirin right, left, and center just as a drug which ecosprin AV or ecosprin is being used so commonly. I recently have a personal experience of a very close friend of mine, a senior person around 55 years of age. And he just called me that there is some issue in his talking. And he got an MRI done by a neurologist and he had a subdural hematoma. Not on aspirin, not on anything, very thin, frail gentleman, hypertensive. Subdural hematoma for what cause, we don't know. And second thing in our country is there's so much of this medicine from Ayurveda and other things and the concoctions which people are taking for their blood pressure. You don't know what is in that. They may predispose to bleeding, the substances we are having in food. So I think we need to go in detail and depth about these patients. And obviously, once we have a diagnosed AF, then anticoagulation becomes class 1. Aspirin should be out. Thank you, sir.
Absolutely. So whenever we, giving antiplatelet along with anticoagulant is something that we should really restrict ourselves to only few situations. When the patient has undergone a revasc procedure within 1 year, that's the only situation where we combine the two. Otherwise, anticoagulant is good enough for all stable patients and all patients with angioplasty or surgery beyond 1 year of the procedure. One more related point for the benefit of audience, we may say that often we face challenge of the restarting anticoagulant when the patient has had a hemorrhagic stroke. So we must, and there is a very simple formula for that. With patient with mild, moderate, and large stroke, we can, or TIA. So TIA we can start next day only. In mild stroke, 3 days. In moderate stroke, 1 week, and large stroke, 2 weeks. But we must, in moderate and large, we must do a CT scan before restarting to look for any hemorrhagic transformation. And with the clear intracranial bleed, of course, there is a big issue about when to restart. So, Vinayak, what is your practice in those patients where patient has had a significant bleed inside the cranium?
So actually, that is a tricky subset because there are no clear-cut guidelines. It all depends on the size of the infarct, size of the hemorrhage. There is a lot of hemorrhagic transformation which can occur in large infarcts. And that can dent your chances of restarting these patients back on anticoagulation. So usually they wait for about 2 weeks or so for the bleeding to subside. There is a lot of, the neurologist will keep doing repeated CT scans, say after 3 to 4 days to see if there is an increase or not. But overall, I think it's a clinical decision more than any stipulated date, which will determine as to at what time you will restart these, anticoagulation.
And then we will want to switch to a agent which has shown the lowest incidence of intracranial bleeds, say apixaban, for example.
Apixaban, yes. Now, actually, in the elderly age group, the data is more towards either apixaban or dabigatran. less with rivaroxaban, and
Lower dose of dabigatran.
yeah. So I think most of us, even if there is an indication for 5 mg twice a day of apixaban, in these patients we usually start with 2.5 mg twice, or lower dose of the other anticoagulants like rivaroxaban or dabigatran, if that is your primary choice. So I think the idea is to balance the risk of thrombosis versus bleeding. Bleeding is as important as thrombosis, especially when there is a stroke and a hemorrhagic conversion.
Thank you. Very insightful comments. So now we can move on to the next case, which will be presented by Dr. Yeah. Any comment by anybody?
Sorry, sir. Yes, sir. I'm sorry. This is Dr. Mathis. So it's just a question. It's not related with the current topic. There is a patient, a young 36-year-old male. He's a known case of chronic pancreatitis, and he's asymptomatic right now. Unfortunately, CT revealed, his MRI revealed that basically he's having portal vein thrombosis and mesenteric vein thrombosis. So in this case, like the data suggests, basically giving warfarin, maintaining an INR between 2 to 3, and of course starting it with the Clexane or heparin, whatever. So is there a role for rivaroxaban or other NOACs in this case? I mean, how?
Basically off-label use, because all these unusual cases have been treated conventionally by either heparin initially and subsequently with vitamin K antagonists. And we hardly have any structured study to study these patients with any of the agents. So one can assume that NOACs may be effective, but that will be off-label indication. We have been surprised by the studies on mechanical valve by dabigatran, Realign study, where we found that there was a problem in those patients. So one doesn't really know. So I think it is safest and least controversial to stick to vitamin K antagonists in that situation.
Can I make
no one can blame us. Yeah, Samir, please, your comment.
Yes, sir. Yes, sir. I think it's a very important question, and we have used off-label in some cases of LV clot and other things, wherein we have found very immediate benefit with these NOACs. But again, after telling the family, and it becomes very easy. You don't need to monitor the INR and other things, so it's very easy. Dietary issues are not there. But something like APLA, antiphospholipid antibody syndrome, usually, in my knowledge, correct me if I'm wrong, NOACs are not indicated. So the kind of case which you are describing, one needs to rule out those hypercoagulable states like APLA, antiphospholipid antibody syndrome. If that is not there, and you don't find it, or maybe we'll have to search literature. Mechanical valves, definitely, but that is a different pathophysiology, and the recent trials have also failed. So that is one place where VKs have to be used. But other hypercoagulable states, I think, apart from APLA, probably we can use. But again, explaining to the family and taking a written consent, because if tomorrow things go wrong, we are medico-legally at least safe. But yes, it becomes very convenient. I mean,
least controversial is vitamin K antagonists.
Yes, sir. Yes, sir.
True. Very nice comments. So I think we can move on to the next presentation by Dr. Ayush Shukla. And he will discuss about the role of NOACs in patients with non-valvular atrial fibrillation, why and when. Dr. Ayush, your presentation, please.
Sir, am I audible?
Yes, yes. Please go on. Thank you.
Good evening,
Yes, sir.
So much has been said about apixaban in different case scenarios. Mine is not very different, but it's a case which we face in day-to-day practice. So my patient is a 70-year male who is diabetic and hypertensive, has a history of previous ischemic stroke 2 years back, is having moderate CKD, CHADS2S comes out to be 5, has blood is 4. So ECG, of course, shows atrial fibrillation. And so what would be the most appropriate anticoagulation in this patient? So we all know that stroke prevention in AF is about finding the balance, and there is a risk for thromboembolic events and risk for bleeding, especially in this case. So the aim is to reduce the risk of thromboembolic events with a minimal risk of bleeding complications. And NOACs have been shown to be non-inferior versus warfarin for stroke prevention. ACC/AHA guidelines have proven that NOACs should be used and can be used before and above warfarin, and various NOACs are there, and of them, when we choose, so we can see that if a patient is having a history of GI bleeding, then apixaban is only NOAC with a smaller number of GI bleeds in the original study. If a patient is elderly, then also apixaban is favorable. Impaired renal function, again, apixaban can be used in diabetes also. So when we have to take a decisional flow chart, so we can see that apixaban is almost present in every column, where we can see the patient is of in different cases, whether the patient is elderly or patient is of renal impairment, or the patient is having a high bleeding risk or previous GI hemorrhage. It is a safer and effective alternative to other oral anticoagulants to prevent stroke or systemic embolism, has a convenient twice daily dosing regime, predictable pharmacokinetic and pharmacodynamic properties, and potentially useful anticoagulation treatment due to fast onset of action and low potential for food or drug interactions, and lack of requirement for routine monitoring and use. So the patient characteristics, all the high-risk patient groups, be it older or having higher risk of bleeding or having previous GI bleed or severe renal impairment or dyspepsia or GRT, we see that apixaban is present in each and every box. So I think we will leave further things for discussion. Sir, over to you, sir.
Short and sweet. This is, I think, a very important thing to understand as to which situation demands which NOAC. So, as you rightly pointed out, patients with GI disturbance, we like to avoid dabigatran. Patients with renal dysfunction, we like to restrict dabigatran again. Patients who are elderly, again, the data is superior for apixaban. One of the things is that rivaroxaban somehow has been most widely investigated for more diverse indications. And what are your views about that? I would ask both the panelists, what are their views about this situation that, I mean, most of the indications have been tested with the rivaroxaban.
Yeah.
But as far as NVAF is concerned, apixaban probably scores the best.
Yes, even in our practice, sir, for pulmonary embolism or DVT, we personally, by institutional practice, rely more on rivaroxaban. But for NVAF, yes, apixaban is our choice.
Because there are many trials going on, and some have been already presented on bioprosthetic valve, on mechanical valve. Also, there is a study with rivaroxaban, bioprosthetic valve, RIVER study. And of course, for peripheral, for CAD, for PAD, everywhere, rivaroxaban has been tested in many diverse conditions compared to other anticoagulants.
Absolutely right, sir. I think I follow the same practice. I use rivaroxaban a lot for in DVT, pulmonary embolism subset. In fact, wherever there is a compliance issue, I actually shift to rivaroxaban a lot of times because of OD dosage. The other subset is, like, recently I had a patient who presented to me with stroke and had dilated cardiomyopathy with an LV clot. And initially we put the patient on clexane, the low molecular weight heparin, and then shifted to warfarin, which is what the class 1 indication is. But the patient refused. The patient said, I'm not going to take warfarin. I cannot get INR done. So then I had to choose a NOAC. I wrote in the file that the patient has refused, got the signature of the patient, because it is still not in the guidelines that there are anecdotal reports for LV mass, LV clot, or, to use NOACs. So I actually started them on rivaroxaban because of the compliance and because of the fact that there are enough reports with NOACs for treating LV clots. So I think what we are seeing is an extension of NOAC use, barring, I would say, 3 or 4 conditions. One is the mechanical valves, the other is your, the APLA, as Samir is saying, and the third is the LV clots, And the fourth one is severe mitral stenosis or moderate to severe MS with AF. So those are the indications. Leaving them, I think we can use NOACs in almost everything under the sun. Which one to use is predominantly your choice. Even in the elderly and the patients, it's not that you cannot use rivaroxaban. There are, I think, a matter of semantics and your personal choices come into the play. But there is very little data or head-to-head comparison between the three.
What are your views, Samir, about the choice of?
Yeah, I think all has been said, sir. And one practical aspect which I think probably rivaroxaban was introduced to cardiologists relatively late. It was mostly an orthopedic molecule. And we actually started it in AF. The indications for DVT came later. So we were exposed more to dabigatran initially and then to apixaban. And we found that the risk of bleeding and other issues. And I think most of the people here would be favoring apixaban in most of the situations. But yes, DVT pulmonary embolism, because orthopedicians have used it and it has been more studied initially. But I think when I put it very beautifully, looking at the compliance of the patient, looking at the risk of GI bleed, looking at a young patient who is very prone to stroke, I think 150 milligram of dabigatran still, I would say, is best, and availability of an antidote also makes a sense. You have Praxbind for the dabigatran, and some of the patients, I remember one of my patients who bled on apixaban, nuisance bleeding, but he just told me, why didn't you prescribe me a drug which has an antidote? This doesn't have an antidote. And he was very educated. So in this modern era of internet and those many things, I think we really need to understand and explain them and choose the right kind of drug for the right patient. And having said about renal failure also, we assume that 2.5 milligram BD of apixaban is the best, but there is data for low dose of rivaroxaban, which is very, very good in that scenario also. It's just how much the company is putting in effort to portray that data. But I think hardly to choose between the drugs, except that you have 150 milligram of dabigatran in one group, which scores over anything else, young patients with recurrent strokes, ischemic strokes, or you have a compliance issue wherein rivaroxaban scores. So apixaban is hitting the sweet spot in most of the situations. Our experience is better. So probably the GI bleed is...
I agree that it offers the best balance of safety and efficacy. Rivaroxaban. Apixaban offers the best blend of safety and efficacy. But I often use, as you rightly pointed out, dabigatran for the maximum, because the best efficacy has been demonstrated by dabigatran 150 twice a day. So in young patients with the good renal function, without any bleeding risk and all the low bleeding risk, we definitely prefer dabigatran 150 twice a day. And then Vinay, there's one more category where I often use rivaroxaban. That is moderate renal dysfunction, and the patient is close to 80, close to 60 kg weight, close to 1.3, 1.4 creatinine, where I'm scared to use full dose of apixaban, and I don't want to use half dose because it doesn't meet the criteria. But their creatinine clearance is around 40, so we can safely use a lower dose of rivaroxaban in that situation, because that offers only 25% reduction from the full dose. While apixaban, you either choose 5 BD or you choose 2.5, that's a 50% reduction. And sometimes you are scared to use full dose and you're not confident about half dose of apixaban. So that's one situation where, and you don't want to use dabigatran also because of renal dysfunction. So in those situations, rivaroxaban comes in very, very useful.
Absolutely, sir. And you'll be surprised, in the last week, I've had 2 patients coming with GI bleed who were on apixaban. So it's not that you don't see GI bleed with apixaban. And what I'm saying is that I think more and more in the last 3-4 years that we've used these drugs, I don't really see much difference between the 3 categories per se. It's not that you're not seeing, the GI bleed with apixaban, or that you're seeing more with the other drugs. I think it's become more of a personal choice eventually. Also, there is a definite bias towards, NOACs in certain indications, whether that's something which is being drilled by repeated, say consensus statements rather than an actual head-to-head comparison, which has never happened. So I think it's something which the message should be that you choose what what fits the patient's profile at that moment.
What do you think is best for the patient? Absolutely. Yeah. So I think we have had very good discussion. I will request our speakers, they have done commendable job. So, but any further comments by Dr. Kavita? Dr. Kavita, are you still there?
Yeah, sir. Thank you so much.
Any further comments you want to make about any of the presentations or anything that we have discussed?
So the point which you just now brought out, I actually learned it from you, that in a scenario where we are not confident about using apixaban 2.5 mg/d, those borderline patients wherein, so I think rivaroxaban is better. That dose reduction is not that much great as with apixaban, which makes it completely harm. That is a learning point. Thank you.
And I think, sir, Dr. Saxena, you mentioned in one of the other meetings also, and this is a very, very nice subset of patient, because if you even look at, and you commented that, I'm just repeating what you said. So Aristotle actually had very few patients on the 2.5 milligram BD dose, and that actually goes against apixaban, versus if you look at the rivaroxaban data and you look at dabigatran data, the number of patients studied with the high dose and low dose are relatively equal or high. So, I mean, we must give more credit to a lower dose of rivaroxaban and dabigatran efficacy than to apixaban. Yes. But somehow or the other, the marketing of Pfizer or maybe those small group of patients, it has seeped into our minds. And Vinayak beautifully put that apixaban 2.5 milligram BID can also bleed. So any NOAC can bleed. You cannot compare the NOACs. No trial will do that. But again, this point is very, very well pointed out, and I use your recommendations in my practice also with renal failure, where I'm not very comfortable using 2.5 milligram BD, and I feel that the risk of ischemia is high. Rivaroxaban probably is the drug of choice.
Thank you, Samir.
This is a very good point.
In fact, that's one problem with apixaban. I feel that 2.5 is very inappropriately used by a lot of physicians, which I feel concerned about.
But I learned this from you, sir, today, that I actually like this, approach of using 15 mg rivaroxaban rather than 2.5 BD. I think that's a very good point to take forward in my clinical practice. I think that's a good suggestion.
Thank you. Dr. Shastri, any further comments from you? We enjoyed your presentation very much. Thank you. Dr. Shukla, any further comments from you?
No, sir. Again, a point of learning. It always helps to hear from stalwarts like you that rivaroxaban 15 mg/d. But one point I would like to say, sir, given the data or the knowledge that we physicians or cardiologists have, all the relatives or known to patient who are patients of atrial fibrillation, 90% of them are on apixaban. So,
yes, that's true. That's a favored molecule.
Somehow we favor, or somehow we rely more on apixaban.
It is a very good blend of safety and efficacy, I believe.
It is. I think it is also a bit of. Sorry.
Yeah, you're saying something, please.
No, I'm saying that I think it is also the act of commission versus act of omission. I think that is also plays heavily in the minds of a clinician. And we tend to follow a trend sometimes because I think it's safer. So maybe it's time to revisit that again and, reanalyze the data, because once it's become old, you tend to forget the specifics. So I think it's never a bad idea to revisit the equation again.
Fully agree. So I think we have had a very good discussion, and it's indeed a strange thing that we have been discussing NOACs for over 12 years now, and still in every meeting we learn one thing or the other from co-faculty. So I think I really enjoyed the presentations by everyone, and thank you all my co-faculty for this wonderful session. And I think we can stop here, and I will also thank Emcure Pharma for organizing it so beautifully. And over to Keor.
Thank you, sir. Thank you so much, and it's really very insightful discussion today we had, specifically on the NOAC, and the kind of insights given by Dr. Moderator, Dr. Vinayak Agarwal sir, and Dr. Samir Kumar sir. Thank you so much, sir. for even for short notice joining the today's program, because it was very important to have, because continue the momentum of no thrombosis program every month we're conducting. And there are many doctors, the PG doctors or the new set of doctors, they always ask for when next month, when you are conducting, when you are when you're doing this program, because case discussion always have a lot of interest and a lot of learning specifically on this. So once again, from behalf of Emcure, so thanks to all over both the three speakers, fantastic case presentation by Shastri sir and Kavita madam, as well as doctors. Our one more doctor is Avish Shukla sir from Lucknow. Thank you, sir. Thank you so much for once again from behalf of Emcure. Thanks to all our faculty member, and also I'm very proud to inform all of you that we are going to complete 2 years for launching our the number one brand, that is Rivaroxaban, and that is Exafib. This in December, we're going to complete 2 years for Exafib. And very proud to say at present it is number one brand specifically in Indian generic brands. And also want to inform you that we have also launched Apixaban, that is Prepixa. That is one more brand we have launched specifically in Apixaban. So these are the two brands we have. So this is all from our end. And once again, thank you to all our delegates for joining today for today's program. So thank you, sir, and good night, sir. Thank you. Thanks, Anil, sir. Thank you, Anil Saxena, sir, for guiding us and for educating us. Thank you so much.
Nice to see all of you. Thank you so much.
Thank you.
It was a pleasure.
Thank you. Thank you.
Thank you, Vinay. Thank you so much.